I'm excited to be here. I love advocating for all different types of conditions, but especially those that are misunderstood. And I think this one falls into that very well. Just a little heads up. I made my slides a little wordy. I made them wordy that way so that you can reference them later. All the main talking points are on the slides. I would just encourage you to try to listen to the stories I share and the main big picture things I want to convey to you. I've been working with Parkinson's um, for about 14 years. I know MSA, CBD, PSP, these are atypical Parkinson um, conditions. I've been working with that for about the last 6 years. The title of the talk is really getting into anticipating and addressing the unspoken social communication and swallowing needs of those with PSP, MSA, CBD. Why is this unspoken? Right? Why am I choosing that word? It's unspoken because the we can't expect the client, the person with the condition, to tell us what their needs are. We can't. Just in my professional opinion, the way it progresses within the person, it's in many ways it's going to be easier for somebody outside of themselves, which is everybody, right? We're on the outside looking in at the individual, and we're likely going to see changes before they do, which I think is really unfair. So it's our job. It's the healthcare professional's job to understand your needs, anticipate them, and provide for them. Um, Again, it's great if the individual can express their needs, but that's, again, in my opinion, not the expectation. Um, what I Just to go into this, there's no financial disclosures. I'm listed as a support group leader for CurePSP, and I've been a lot of what I'm known for in the region. I'm joining you today from Northern Virginia in the States here. In 2011, I created practice groups for people with progressive neurological diseases, primarily Parkinson's, only that it's more common. And then as I started getting into working with more people with PSP and MSA, I went to who was supporting those groups, and I said, hey, I know these people don't have Parkinson's disease, but can we include them? And they very much opened their arms, if you will, and they allowed me to include any client I felt was necessary. So I've been leading groups of people with PSP and these atypical conditions since about 2015. And a lot of what I'm going to talk about today is what I learned from leading these groups. Not so much from reading research, not so much from treating individual people, but leading groups of people. And it was really eye-opening to me. So that's going to be a big part of what we talk about. All right, I'm not going to build my case for you. I'm not going to spend 6 slides building my case. This is the main thing we're going after here. Big picture action items. Again, I encourage you to kind of follow along with me as I go through it rather than reading along. I know from working with people, if you're reading ahead of me, you're not listening to what I'm saying, and you may miss out on some important information. So in all my years of doing this, these are the primary things. If when we go through each of these things, if this makes sense to you and you know how to implement it and you know how to get these resources and you know how to provide these things to the individual, in my opinion, you're going to give them a great quality of life. I think some people will stumble upon this information after the fact, maybe later on in advanced stages of the disease. I want to give it to you ahead of time. Biggest thing, build and maintain a strong voice. Okay. You might say, my voice is okay right now. I don't think I need to work on this yet. It's great if you can speak and you're understood. What's, again, how we said that the condition's going to progress in ways you can't see, right? So if you're starting to have trouble speaking, you already missed the symptoms. A big thing in communicating is the strength of your breath support. right? Even people who don't have neurological diseases fail to speak on their breath support. It's something we take for granted. If we asked all of you, how are you speaking right now? Can you tell me? Can you tell me what's actually happening? Chances are you can't. So if you can't tell me how it actually occurs, how are you going to strengthen it? How are you going to train it? How are you going to make it stronger so that you can offset the progression of the disease and possibly push off the symptoms for months or possibly years? So biggest thing, build and maintain a strong voice. We don't expect you to do it. This is our profession. Speech pathologists, you need to go see a speech pathologist. It's our job to teach you. So that's number 2, right? Everything we're talking about today is speech and language pathology. So if you don't have one on your care team, I highly recommend getting one, finding one. Now with telehealth being so prevalent, if there's not one local, you can probably have access to maybe one from a bigger hospital system somewhere within your state or country that you would otherwise not have access to. Number 3, right? You might think this sounds like a Yogi Berra quote or something if you're familiar with his quotes. We have to live while we're alive. This is the big thing I learned from leading groups. We have to have fun. All right, let that resonate. No matter how progressed the disease is, we have to find ways to laugh. Okay. And a lot of this can be achieved through self-expression, right? How we choose to express ourselves. I was thinking about it in a sense, if you go to like a comedy show or something, sometimes a lot of what makes that comedy show funny is not so much the content, but the mannerisms of the person and the facial expressions and how they choose to express themselves. I think that's what makes it funny. This is something you and I can do, right? Everybody, the person in the tech room right now can look over to his buddy and go, what is he doing? And make this funny expression, and it'll probably cause somebody to laugh. People with PSP, the conditions we're talking about, you can do this. You can sit there and look at your loved one and raise your eyebrows and, give them this funny face, and someone will probably start laughing. Not laughing at you, right? You are evoking this emotion out of somebody. But this is a big quote I hear a lot. Laughter makes me feel better than any medicine I take. Right? Think about that. Laughter makes me feel better than any medicine I take. Right? Look into your own lives. How much of your day do you dedicate to laughing? Right? Maybe none. Right? How smart are we as human beings if we don't give ourselves the one thing that we know makes us feel great? Meeting the psychosocial needs. All right, this is, again, you can't expect the client to say, hey, you know what, I really need to, talk and compare notes with somebody. These are things, again, we take for granted. If you have friends, right? If you have friends, think, why are you friends with that person? Why? Think about it right now. Everybody, think, why you're friends with who you're friends with. It's likely because you accept each other, right? You get each other. You like similar things. On some level, you just, the term is there, acceptance. When you have a condition that starts changing how you feel, while you may be surrounded by loved ones and friends and people who really care for you, what you're likely going to be lacking is empathy. Right? And empathy is shared thoughts or feelings on something. That's the standard definition of it. But empathy is just the feeling that, hey, you get me, right? And even though I know a lot about these conditions and I think, improve their lives pretty well, I don't have the condition. It doesn't matter how much I learn about it. I think it's unfair for any healthcare professional, anybody who doesn't have the condition to say, yeah, I understand you. I know what you're going through. I think that's almost insulting, right? Because unless we have the condition, we just don't know what it feels like. But, right, somebody else who does have the condition may, right? So the purpose of groups and bringing people together is to give the individual empathy, understanding, acceptance of themselves, to maybe see, hey, Joe has this. Joe's doing pretty good. Why do I feel so bad about myself? I've heard this from many clients in the group. They say, it forces acceptance. In a way, I think that's a good thing. Otherwise, if you haven't fully accepted it, you may not do what you need to do to help yourself because you're maybe in denial. I'm not saying that's a bad thing. It's perfectly understandable. But the sooner we get on board with taking action, the better off we are. The other one on here is purpose. I've had clients that with similar conditions that, purpose is, why do you get up in the morning? If you had a career that gave you purpose, you got up, people were relying on you for things, right? You had to show up to fulfill those things, right? These are the prime of life diseases. Generally, most people are retired when they are diagnosed, or it may force them into retirement. And they may lose this sense of purpose. It's very important in my experience to fill that with something. It could be, something as simple as going out and filling the bird feeder every day. Obviously, with balance issues, that may not be the best example, but you need some connection to the world where it's depending on you to show up for it. I'm sure you guys understand. Number 5, I just sort of talked about that. Meet others with your condition. You get some pushback from this. You say, "Oh, I don't want to see what I'm going to become." Well, how do you know they're worse than you're doing? It's kind of judgmental to think that you're better than everybody else. Some people are thinking of support groups in the sense of just, what am I going to get out of it? Right? That seems sort of almost selfish, right? Just me. What am I going to get out of it? What if by you showing up, you help somebody else? Did you ever think about that? I've seen that. I've seen that in my group. I've had people come and say, and they get really teary over it. And it was over somebody who had MSA, and it was somebody, the individual had Parkinson's. And he said, I'm going to keep showing up as long as Ron shows up. If he has to go through all that to get here and he shows up every week, I'm going to keep coming. Right? So Ron maybe is coming for himself, but Ron doesn't realize he's actually inspiring everybody else around him to show up. It's extremely meaningful. And the last one goes right into the same thing. Join or create a communication practice group. So this is something I started doing again in 2011. Essentially, saw this primarily with Parkinson's. You treat them, they do better. But I'd say just about everybody does better. The biggest thing in therapy, the two big prognostic indicators as to whether or not somebody's going to do well or not is, one, do they want help? Right? Again, that doesn't mean you give up on them. I'm very much a motivational coach. I want the problem children out there. I want the people who are resisting help. Because I don't want they're hurting themselves on purpose. They're purposely pushing people away. And I don't want to see them do that. So generally, I'm pretty good at motivating them to act. But do they want help? And how good is the individual's memory? And we'll get into that, right? Two basic things as far as will this person do well in therapy or not is, do they want help? Are they accepting of help? And again, some of that goes into the accept the condition. And are you able to remember and apply new information? Sort of went off on a tangent there, but coming back to this. So again, if you can understand and meet these needs, the remainder of the slides aren't as, they're all valuable, but they're all sort of defining this stuff further and the value of this further. Speaking of purpose and whatnot, again, you can have somebody who has difficulty with their memory. And if they have something to look forward to, like genuinely look forward to, they will remember what day of the week it is, because it's on Tuesday that I get this group, that makes me feel alive, or it's fun. I feel better after the group. The body will have this draw to it. I say create your own practice group. You don't have to be a speech pathologist to create a practice group. The big thing in therapy is get therapy now, learn what you got to do, allow the therapist to train the caregiver as well. Again, we can't expect the client to do these things on their own. Doesn't matter. I'm not trying to insult you. You could be the smartest person in the world, the hardest working person in the world, have the most resources in the world. Just the nature of the condition, you need an external model, external feedback to really do the exercise as well. All right. I went through this already. Where's my knowledge come from? I have well over 10,000 treatment hours restoring voice and swallowing disorders in people with progressive neurological diseases. I've created and led Parkinson care teams. This is, again, trying to advocate for the condition, trying to inspire other professionals to, at this time, see my vision of it. It's not just me. That's not what I'm saying. Get them to realize we can all do more. We're treating them, but we can do more. And the answers to each professional niche is with that professional. So we really need a team of people involved. I did that for about 7 years or so. Programs I've created have been spread to just most large hospitals in my region. Of course, COVID ruined that for us, but a lot of that's gone to Zoom now. And I've led over 1,000, that's a lot, 1,000 of these meetings with people with Parkinson's and atypical conditions. 1,000, over 500 of them have been via video teleconference since 2015. I think it speaks for itself. I clearly enjoy it. It's definitely the highlight of my week, is to have fun with these individuals. All right. If everyone could do this for me, please take a few seconds. List off the top 5 things, maybe 3 things. We don't have a lot of time. That immediately pop up in your head, and what allows you to function as well as you do. Just think, how did I do the job I did, or how am I this performer? What is it? What is it that allowed you to perform at the level that you do? It doesn't have to be spectacular. Just what is it? What do you think is influencing that? What's the foundation of your abilities, right? All right, hopefully you thought of something. All right, so I thought about this for 15 minutes or so. These are my top 5. What allows me to do so well? I have control over my muscle movements. My body does what I expect it to do. I can, if you can get your body to do what you want it to do, you can do a lot of things. In the grand scheme of living, though, what it allows me to do is it allows me to swallow water. I can be hydrated, right? Big thing, right? If you can't swallow water, you can't be hydrated. We're going to have major issues. I can eat without difficulty, right? I can meet my nutritional needs. I can get where I want to go without falling or fear of falling. I can be heard when I speak. You can do a whole lot if you can be heard, right? There are certainly other ways to communicate, but speaking is very efficient. I can take a deep breath in and exhale hard, right? I have control over that. Or if you haven't picked up on it yet, I didn't really think about what is it that I'm allowing to do. I thought about my clients, and I thought, these clients, they can't work anymore. They can't drive. What is it that they've lost that is what is making it hard for them to live life as well as they could have before? Okay, this slide is mainly for caregivers, friends, family members, people who don't have the condition, right? I talked about empathy. I want you to really try to understand what it is these people are living with, what it is they have to contend with every single day. And those that are doing well with it and fighting it, you should be very proud of yourself. Seriously. I'm not trying to patronize you or anything like that. You're working hard every day. And I admire that, and I support that. And I want to play my role in the community to make sure you do well. All right, number two, right? I can learn, remember, and apply new information. Big word being apply. All right, sometimes what you see in these conditions and other neurological diseases is you can teach someone something new, right? We'll use a walking example because that's something we can see. Everybody can relate to that, I think. And you tell someone you're not allowed to walk on your own because you're gonna fall backwards or something get hurt. All right, and the person says, "Okay, I got it. I'm not allowed to work. Not allowed to walk on my own." All right, great, right? We fixed the problem, right? Then they got to go to the bathroom. What are they going to do? They're going to get up and walk to the bathroom. And then, in this scenario, they're going to fall. And then the caregiver is going to come back and say, "Well, you got it. You told me you weren't going to walk. I know I'm not allowed to walk, but I had to go to the bathroom." So anyway, there's a difference between learning information and then taking that information and applying it into your decision making. Okay, so for those of you who don't do health or rehab, it's important to remember that distinction. You cannot just tell somebody something and expect them to apply it in the right context. It doesn't always occur. People who have had strokes on the right side of their brain are notorious for this behavior. And again, sometimes you see caregivers getting mad and it's not his, her, they. It's not their fault, right? They have a neurological disease. All right, it's our job to understand it and anticipate it, and not put them in a position they can't get out of. All right, stable social emotional well-being. Oops. Sorry about that. No, you can't. Anyway, I've lost you on my screen here, but I'm going to keep going. There we go. We're back. Again, this gets it back, and this is huge, right? If we're not doing something to hold off, I'll say it, depression. In some ways, it doesn't mean as much if you've got a ton of resources and you know what to do. You've got an individual who is not motivated. If we're not, this applies to all of you, right? The reason why we do things is because we're motivated to do it. If we're not motivated, a lot is lost. So I feel like a lot of this can be achieved in a positive group setting, where the person, again, is meeting these social emotional needs that they're likely never going to express to you. Again, with the right instruction, I think just about anybody could lead these groups. And again, I encourage you to, if we took all the speech pathologists in the world and all we did was treat Parkinson's and atypical Parkinson's, there'd be more need than resources available. So if we can empower you to do this, that'd be great. All right, I'm going to skip ahead here. Best time to act is now. If you haven't gotten that message yet, I'm going to skip to the bottom here where it says, our muscle strength, right? Our motor learning ability, our cognition, our ability to think, remember, learn information, our ability to recover from things, right? It generally gets worse as we age, right? I already feel it now. Your best opportunity to work on this is now, right? So the idea being, to jump back up here, I'd be at symposiums and somebody would come up to me and say, "Hey man, do you think I need speech therapy yet?" There, and I'm leaning my head forward, I can barely hear them, and I'm trying to be pragmatic about it. I'm saying, "Yeah, I think it's probably a good idea to work on it." And they say, I don't think I'm there yet. I don't think I'm there yet. Like, where's there? Like, there sounds worse than here. So you're telling me, you're already not so great now, but we're going to wait until it gets worse, and then we're going to work on it. That makes zero sense. Just putting it out there. When we never want to get there, wherever there is, we want to get now better, keep now, and work to keeping now better. And then if things drop off, get more therapy, and then try to keep going. But it's not a therapy, no therapy for 6 months therapy. It's therapy. Learn the exercises, do them every day, have fun doing it, live life, create relationships, laugh, enjoy what you're doing. I think you get it. All right, huge thing here. Swallowing and voice, roll of cough and throat clear. If you can just skip down to the bottom here where it says strong voice equals promising cough, throat clear. Yeah, I guarantee you no one there is thinking, "Hey, how's my cough today?" When we swallow and food doesn't go down as it should. Kind of the only defense you have that you can purposefully do is to then cough it up or clear your throat. That's a cough. Okay, you can lose that ability. Sorry, not saying it to hurt your feelings, telling you so you know. This is going to sneak up on you. There's a huge correlation. I'm a voice therapist, been doing voice therapy for 17 years, and again, working with Parkinson's and whatnot for 14, 15 years, and even saying a lot of times you fix the voice, and it's not the vocal quality that's helping you swallow better. It's your control over your lungs, your breath support, your ability to close your airway, your ability to blow air up and out of your throat. That's what's doing it. So generally, a strong voice tend to see a stronger cough, stronger throat clear. A weak, breathy voice, someone who's talking to you like this, likely a weak to even absent cough or throat clear. Absent, meaning I'll ask them to cough for me and I'll get, I'll ask them to clear their throat. There's nothing there. That person is in a bad spot. They don't have defense. That's their purposeful cough. You will likely have your reflexive cough. That's different, but that's out of your hands. That's your body overriding sort of our incompetence, right? There were signs there. We should have coughed. We didn't cough, and now our body is making us cough. The reflexive cough tends to stay there. But again, we want control over our own body. The basics of voice therapy in atypical Parkinson's. We want a strong and coordinated abdominal breath support to generate intensity. We want to forcefully be able to blow out air hard and fast, right? So if we can start the sound, we can likely sustain it, right? That makes sense, right? If you can't start the sound, what are you going to sustain? There's nothing to sustain, right? And our voice works because our vocal folds vibrate. And in order for them to vibrate, we need air to come up. In order to have air to come up, we need some abdominal power to, hey, right? I don't just do that, right? I purposely do that. I take in air and I force it out. And I'm training muscles to do that. People with these conditions can learn this. Way more promising to do this before you have any issues at all. Even if you're having some issues, you can likely still do it. All right, I'm watching my time. This is interesting. Finding the connection with emotion and movement. This is what I found out in my group. So here I go. I'm there in my circle of people, and I'm having them shout, "Hey." Okay, and I'm getting "Hey," and it's sounding okay. There's no facial expression. There's no gesturing. There's no body language whatsoever. I ask them to point at me. I want you to point abruptly at me as you say "Hey." So you can even see, if I say "Hey, hey," right? Things change in my body. My intention in the communication changes. All of a sudden, I have expression on my face. All of a sudden, I have more body language. I do more. So I found across the board, if you have them punch out or this or anything, I say in the group, just don't offend anybody, but do something. I've had people with Parkinson's jump out of their chairs. I didn't ask them to jump out of their chair. I just asked them to move their body. And all of a sudden, they're standing up in front of us. The other neat thing is using emotion. All right, I learned this from my first person with PSP. I came in, he was whispering. You couldn't hear anything he was saying. You'd think, well, Matt, can't you hear a whisper? No. I had my ear down to his mouth, could not hear anything he was saying. He didn't make any effort to speak louder. He seemed to think the way he was speaking was perfectly fine. Wife was distraught, saying, Matt, you can't not work with him. You got to find a way to work with him. I tried everything in the books to get his voice to turn. Nothing worked. And I thought, again, I want to help people. So I thought I'm going to, this guy was, he was driving his Prius, a big environmental guy. And I thought I'm going to irritate this guy, professionally irritate him. And I started, mocking his priorities in life and whatnot. I said, I'm going to go out to your car, Bob, and write, I hate the environment. And he had the most expressive expression on his face than he had the whole meeting. And he's, no, you're not. Boom, this loud voice pops out. I was like, where was that? There was no, voice science behind that. And, we went back and forth. He knew we were joking, but he kept his voice louder. We could hear it perfectly fine, actually. And then once it was on, then we could keep it. And that's the way our relationship went. He'd come in, he was whispering, we'd argue over whether he needs speech therapy or not. There are other techniques and things I'm leaving out. But the point is, if you give them this idea, this emotive response, it's sort of like a reason to communicate. A lot of times you get communication, and I hear it all the times. Matt, when they're angry, I can hear them perfectly fine. But when they're not, you can't hear them. So I know I'm running out of time here. Let me play this example. So this is somebody with PSP. She was diagnosed 9 years ago. No, she was starting having symptoms 9 years ago. Was diagnosed 5 years ago. This video was 2 years ago. Hopefully it'll play. We're going to fight this thing, all right? Or use both fists. Why not? All right, and we're going to take a breath in, and we're going to punch the air, and we're going to say, hey!
Hey!
Yeah, let's take a breath in. Hey!
Hey!
Good, even louder.
Hey!
Good, we're going to fight this thing, right?
Yes.
Yep, just put it in front of me and I'll take care of it.
Hey!
Good, take a breath, shout hey.
Hey!
Good, so as we count, we're going to put our whole body into it, and we're going to act like we're going to take care of this condition ourselves. So with every number, we're going to take a breath in, punch the air, and shout that number. 1!
1.
Come on, Lynn, give it.
1.
Good. Next.
2.
Good.
3.
Good.
4.
Good.
5.
Great.
6. 7.
Good. Keep looking at the people. Let them know you're working for them.
8. 9. 10.
Excellent. Very good. So that was Lynn. She gave her consent for this. So that was 2 years ago. She still attends our practice fun groups. I just saw her yesterday. She still has a voice. It's more garbled, but she can still say yes, no, hi. She can shout these fun phrases here. So I think this is my last slide. So if I can finish this up, we'll be half decent here. All right. So voice practice groups. Essentially, all we're doing, like if once the individual has the general idea of how to put their voice out there, I found, in leading these groups, I thought, okay, great, I'm going to have them here. We're going to do all these great exercises. It's going to be awesome. Again, they want to have fun, so we ended up saying these outlandish, these strange things that you'd never say in the real world, but saying it in your group is actually kind of liberating and fun. So the goal here, as it says here, the goal is to have fun, don't hold back, be expressive. So I gave some examples of phrases. I was really questioning whether I should put this up here or not. I kind of sound like a weird person here, but anyway, so if one of the phrases is, what are you talking about? We're not going to say, what are you talking about? Go ahead, if you're at home, do this with me here and think, how would you say that phrase to just let it out, right? It'd be like, what are you talking about? Right? Hopefully somebody's laughing at it. But what you get is, we got our gesture, we're going to get our facial expression, and we're likely going to get volume, and we're going to get inflection. We're going to get the whole picture. This is what we're going for in communication, is being expressive. What we're not going for is flat affect, right? No facial expression, soft voice, no change in stress, no gesturing, no nothing, right? That's what you're at risk of getting. So not only does this sort of encompass this, and I'm not saying this is a therapy per se, but if you want to see more life in your loved one, doing this is fun and comical, and you're likely going to see more life. You want me to do what? I did that yesterday. If we're trying to motivate them to take on the condition, bring it on. Come on. Is that the best you got, Lynn? Come on. Bring it on. Um, once the voice group is up and going, we do a lot of inspirational, affirmations. Say with me, I will not give up. I'm stronger than I know. I can do this. It's again, trust me, it's fun. Again, if you're there with someone, look at each other and go ahead and throw your hands up and say this to them. You'll probably get them to start laughing. All right, almost on time. Let's do the questions here.
Can you hear me, Matt?
Yep.
Excellent. Hello, everybody. Thank you, Matt, so much for being here and for your valuable insight and your riveting presentation. I really appreciate all that you've brought to today's conference and for all that you bring to our community at large. So we did get some questions, and now is the time. If you have questions after hearing Matt's presentation, please put them in the chat. If you do not see the chat, please click the 4 lines on the bottom right of the screen and the chat should appear. But we did receive some questions during registration, so we're going to go ahead and get started with those. The first question for today is it common for a person, or in your experience working with the progressive supranuclear palsy population, to have a person with sudden and dramatic loss of function and confidence? And if so, do you also see that in addition to speech therapy, that physical therapy and occupational therapy and maybe even diet might be beneficial in slowing that dramatic change?
Yeah, absolutely. It's a team approach. When I was through the National Parkinson Foundation, they put together something called an Allied Team Training Program, which I took in 2012. And that was the guidance I got to start a Parkinson care team, which is comprised of physical therapists, occupational therapists, speech therapists, massage therapists, nursing, really any healthcare professional that wants to be involved. We all serve a role in the individual's life. So I'd say, if you have the condition, you want to start building out your team of people so they're sort of there as you need them. Can there be significant changes? Yes, absolutely. Is it going to happen to everybody? No, I'd say, just in the sense that everybody's different. What was the other part of that question? Just lack of self-confidence. Yeah, again, I think when your body isn't there for you and you're not calibrated, the wires aren't hooking up to each other. It's right. If we can empathize with that, it's got to be extremely disconcerting, right? Trying to have a client walk from one place to another. I mean, it almost looks like they're trying to walk a tightrope at times. You got nothing to hold on to, nothing to prevent you from falling. Right. So I think anytime you can improve function, you're going to get more confidence. Maybe we'll leave that answer there.
Thank you, Matt. So the next question that we have is about communication ideas for patients who have lost the ability to speak or type or keep their eyes open. Wondering if you have any experience working with patients who might be further progressed.
Yeah, that's a very challenging circumstance. I'd say, in speech therapy, we're only limited by our creativity. So any motor movement they have purposeful control over, I mean, is what you're looking for. When I work with people, I work on them just raising their eyebrows, right? At first, it's like it's not connected. When they try to raise their eyebrows, they're looking up in the air. But then you train it, and all of a sudden they can, raise your eyebrows. Again, that's part of facial expression. But the point is the ability wasn't there, and then we trained it, and then it was there. And then that gives them some purposeful way of communicating something to you. I don't know if they could get Botox injections into their eyelids for it sounds like symptoms of blepharospasm. I know with my clients, the results of that are varied. Yeah, but really, you're looking to train or get any purposeful movement, and then use that as a means of communicating. I'm sorry, I can't be any more helpful than that. Next
Thank you for
question.
answering that question. Absolutely. Wondering if you can elaborate on language and swallowing differences between CBD and PSP.
I can't. I think I've worked with one or two people with CBD, maybe 6 people or so with MSA, and probably a dozen or so with PSP. So I'm not comfortable
Yeah.
discriminating the differences between the two. Um, the difficult thing with all of these conditions is everybody's different. I've never had 2 people with PSP that were the same. I can say, with PSP, again, that's a large, I think I have 5 people on caseload now. Sometimes we use these words interchangeably or whatnot, language, versus speech versus voice and whatnot. Well, one, if you can't speak, right, language doesn't really matter. Language is the content of what we're saying or the content that we're receiving. It's not speaking. Speech is the actual act of speaking, and voicing is the quality of the sound that's coming out, right? If we don't have a voice, we can't speak, right? Your articulation could be perfectly fine, but if you have no voice, there's not going to be any speech. But I'm proud to say pretty much every client I've had with PSP has maintained a voice through their life with the condition up until probably the last few weeks of their life. I bring that up because I didn't realize how significant that was until I went to go visit other support groups or meet other people who maybe aren't getting the specialized speech therapy voice care, or maybe their case is just different, right? But just that there are stories out there that people have lost their voice for a year or maybe 2 years. Um, it's obviously we don't have control over anything, but that's not okay. We need to do everything we can to preserve that, and essentially doing these. I basically showed you. Looks and sounds pretty simple, and it kind of is. Once you know what you're doing, it seems to work. To just preserve that voice, which then allows them to speak, which then allows you the opportunity to use language. Sorry. Roundabout answer.
Absolutely.
Hopefully that
No, thank
somebody.
you. We've got time for one more question. Wondering if you can speak a little bit about liquids. We have one question that says, how can I get more liquids into my mother, the patient, since she is on thickened liquids and needs to be spoon-fed? Also, just advice to avoid choking when the person living with the diagnosis does not care for thickener.
Yeah, this is a great question. Probably a 30-minute presentation here. Well, it's a great question. So in general, we try to put off putting people on thickened liquids unless it's the last possible solution. There is a misunderstanding. You can look up this in the research as far as, the big reason why we're putting people on thickeners is because we're trying to reduce their risk for aspiration. Aspiration can lead to aspiration pneumonia. Aspiration pneumonia can lead to hospitalization. Great speech therapist there. Hospitalization and possibly death, right? So it's a very important subject. Most people don't like thickener and they won't drink it. So one, you got to consider if you're providing an intervention that is not fixing the problem or it's making the problem worse, is it really a solution? And in some circumstances, no, right? You may actually make a bigger problem. If you dehydrate the client, you're going to have major issues well beyond the swallowing thing. We cannot live with dehydration. It's going to lead to hospitalization. We're trying to guard against aspiration pneumonia. Aspiration pneumonia, the actual infection, is more linked with taking bacteria or food from our mouth into our lungs, and that causing the infection, not so much the act of water going into our lungs and causing the infection. So theoretically, if your mouth is clean, you have to go to oral care and you teaspoon them thin water and they aspirate it, meaning they may not get aspiration pneumonia. There's plenty of research out there about it. So sometimes if thickener is needed or indicated, sometimes we'll give them thin water in between meals in the absence of food. After we clean out their mouth, we'll give them small amounts of water. Not just for hydration, but quality of life. It's pretty miserable to have a dry mouth. You're not going to have a happy camper. And there you go. You got somebody who's depressed and not motivated. You're not going to see a lot of any good occurring, in my opinion. So I have 2 clients now, one with MSA, one with PSP. They probably have severe to profound dysphagia, which means they're likely aspirating a little bit of everything. And she's been eating still for 2 years, has never had aspiration pneumonia. She has a voice, though. She can cough, as opposed to maybe a client that doesn't. The other person, just pick them up. There's severe to profound dysphagia, which means a lot of what can go wrong is going wrong. The study showed that they were aspirating everything, little bits of everything. They were getting therapy previously that was just focused on the swallowing. They had a very weak, whispery voice when I got them. All I worked on was voice, as the other person was working on the swallowing. And when I got them, they weren't eating or drinking. They did have a G tube in, so that was meeting their nutritional needs. But the point is, just in working on the voice and trying to get them more expressive and louder and everything, one, the voice got better, got about 300% better in 2 or 3 weeks. And I didn't even work on the eating, and they started eating again. And they were eating for, I even recommend it. It's not a good idea to eat based on the swallow study. And they're eating 3 meals a day or so. There's no symptoms of lung issue or aspiration or anything like that. So you shouldn't take this and apply this to your particular case. It's just an example. But you got to be hydrated. You can look up, it's called a Fraser free water protocol. You can do Google Scholar search on that. It talks about allowing thin water, even if we know people are aspirating. You'll probably find related articles about what actually causes aspiration pneumonia. But so what we might do is give them thin water in between meals after oral care, and then give them thickened liquid with meals so that they're not aspirating the food, bringing the food down into their lungs, if that makes sense. Because anyway, the thickened liquid might allow them to swallow the food down better than if they were drinking a thin liquid. So there you can get your hydration and you can eat, and the patient's happier and they have better oral hygiene. Sorry.
That's extremely helpful. No, that's extremely helpful. Thank you so much for such a pointed answer. Unfortunately, that's all the time that we have today. But Matt, thank you so much for your time and for being a part of today's conference and being a part of our community. Up next, we have Mary Jane Berry, who is going to be presenting on navigating Social Security disability benefits. Matt, we'll see you again soon. Thank you so much.
Thank you very much.